James Moore, welcome to the Pacey Performance Podcast. It's great to have you.
Thank you very much for inviting me on board. Appreciate it.
It's my pleasure. Thank you for fitting me in a very, very busy schedule. It's an honour to have you on, so thank you very much.
No, absolute pleasure.
Anyone doesn't know who you are, James, would you mind giving us a little bit of an intro on you, just a minute or two, and then we'll dive straight into the talking points, which are going to focus around hip and groin injuries.
Sure, no problems at all. So physiotherapist, qualified, 25, nearly 26 years now, studied at King's, did a postgrad in advanced physiotherapy in Australia at University of Queensland, but specialised in neurophysiology, pain science, and then did a second postgrad in engineering at Strathclyde with obviously a biomechanics angle to it, but it was more of an engineering. Clinically, worked in cricket for about 5 years, overlapping with track and field athletics for 9 years through 2 Olympic cycles, Beijing and London. England rugby, 2009 to 2012. Saracens, head of medical there for a little over a year, and then was going to have a bit of a career break because I felt like I'd done a lot by 2012, 2013, and then kind of fell into heading up the intensive rehabilitation unit for the British Olympic Association, and rather fortuitously got made head of performance for Team GB through Sochi, Rio, Pyeongchang, and then setting the strategy through to Tokyo 2020. So headed up all the science and medicine team for Rio, and was again very, very lucky to be awarded the role of deputy chef de mission. So like the second in command, there's 3 deputies behind the chef for that. And then since then, again, decided going to have a bit more of a career break in 2019. These things don't always work out. I'll take a message somewhere there. And sort of, again, started consulting for Andy Murray around his hip after his hip arthroplasty surgery, and now sort of lead his team from a science and medicine point of view and look at the strategy, trying to get him back competitive on the I mean, he is competitive now, but really competitive on the international stage. And then we've got a clinic in Harley Street, which I've run for 11 years, called the Centre for Health and Human Performance. We've got an education company for physios, which is both online and face-to-face, and that's where all the passion for hip and groins come from, where I've been teaching on that for 16, 17, since 2004, so 18 years. And then, just some other consultancy work that I do around and just problem solving. So pretty varied. I've got just final 2 things. I've got a background in strength and conditioning, trained in the US about 22 years ago, and a background in exercise physiology with American College of Sports Medicine. So quite varied, really, and just try and help people and help athletes.
I'm going to let you go, James, because you're making me feel like an absolute fraud.
That's fine, mate. Don't worry about it at all. I'm just very, very lucky. I've been right place, right time in my career, and lots of people will ask me, have I shaped it? And again, just opportunities have come up, and I've left jobs, I've walked away from different things, etc. And I've always been very lucky to find something bigger and better afterwards. So I'm very lucky, man.
How do you juggle being a business owner with obviously a clinician as well? Do you enjoy that side of it or not?
Yeah, absolutely. I love challenge. I love variety, etc. Like I think before, it would have been really difficult in the sense when I was working full-time in elite sport and full-time for the Olympics, because that was a pretty full-on job. They used to have about 7 people all working part-time for 2012, and then they all variously moved on for different reasons. And then I came on board and kind of tried to take on 7 people's roles, which is just gives you some insight into sort of my mentality, I guess, then in lots of different ways. But look, we've set the business up really well, that it runs very well through our operations and management team, and then I can add a little bit of extra insight from a clinical point of view, and I just really enjoy coming back and trying to provide my skills that I've learned within sport back to the everyday person, but then also treat and consult for other athletes in different fields. So we still get a lot of professional and Olympic athletes coming through the door that want second opinions on stuff and want a bit of direction and guidance as to where to go. So I've got the balance quite nice. It's 2 days a week clinical, and then the rest of the time to sort of develop other areas and work with Andy or work on the business, etc. So
Nice. And just as a bit of a fanboy, I suppose, is Andy on track to where he wants to be at this point in the rehab, or along the return to performance journey?
From a physical point of view, we're in a really, really good place. I mean, he played nearly 12, 13 weeks in a row last year at the end of the season off the back of having some pretty major niggles, and came through that without any issues. He's come through the Australian Open. And if you are a fanboy and you watch the Basilas Philly, that was nearly a 4-hour match, and he came through that without really any issues and felt really good for the Taro match. I think, and you really indicate this, the difference between return to sport versus return to performance is probably different. So one, his expectation is super, super high, and rightly so. He's still got the talent, he's still got the tennis skills, he's still got the tennis IQ to play at the highest level. I think there's no substitute for missing what is in essence 4 years of competitive play, if not more, slightly more than that. If you go back to 2016, I think he played 87 matches in 2016 when he was world number one. You know, now we're probably, I think last year we played about 40, so we're at 50%. And so you've got to build that, again, if you want to go acute chronic workload ratios, or if you want to go, right, you've just got to build tolerance, you've got to build mindset, you've got to build focus, you've got to build the repetitive skills. And then you've also got to think about that top end 10% fitness, where he's fit, like his VO2 max is low 60s, which is great for, but at his best, he was low 70s. So he's fit, he's strong, he's deadlifting 270 kilos, he's quarter squatting 260, you know, as an 84 kilo male. So he's a strong boy. He can produce 1500 watts on a watt bike. So physically, we're in a good place, right? But what we've got to do is really transfer that into the consistency on the tennis court. And that just takes time. That takes good coaching. That takes good support and continuity from the rest of the team to help him to deliver.
Nice. Excellent. Well, let's dive into the topic of the chat, which was hip and groin injuries, hip and groin pain.
Yeah.
Probably best place to start for me would be to ask you why athletes get hip and groin pain in the first place.
Great question. I mean, look, I don't know that we have all of the answers yet. So from a medical point of view, we'd call that kind of our etiology. Do we have the exact etiology? I don't think we do. I think we have strong indicators. So we know that if you play a kicking sport, for example, so football, rugby, Aussie rules, Gaelic, etc., you've got a much higher percentage chance. You're probably 3 times more likely to overload your pubic joint and your adductors than you are in any other sport. However, when you start to shift from a kicking sport to twisting, turning sports, and let's call that non-running based, primary running based sports. So let's say it's badminton, tennis, squash, ice hockey, short track, speed skating. Like, you might run as part of your conditioning to supplement the sport, but it's not a primary requirement of what you have to do. Yes, you're sprinting on the tennis court, but you may be covering 3K in a 2-hour, 3-hour match, right? So compared to, let's say, in football. And so we know that when you twist, you increase your risk of hip-related injuries. And then we also know that if you run in a straight line, you also really increase your risk of hip-related injuries. And a lot of that comes down to the cumulative repetitive force within the joint. And what we know is bones generally don't like reciprocal movement, so the same movement over and over and over again. So running in a straight line is generally one of the worst things you can do for bones in lots of ways and joints, and you start to increase that impact loading. And then we also know that women, as a rule, will have a much higher risk of running related injuries in the hip, and men, as a rule, will have a much higher risk of groin related injuries. So when you put all of that together, I think it's really difficult to find a place to kind of hide on the sports field, because if you're running in a straight line, that's your half marathons, your triathletes, etc., your 10Ks, your track athletes. If you're kicking, changing direction, that's all of your, you know, your ball sports in lots of ways, or your mainly football codes, shall we call it, in lots of ways. And I left rugby league out of that as well, which would also be part of that sort of equation. So I think there's a huge risk just within sport. I think then we can look at the other side of it and say, well, I would call it the lumbopelvic hip complex, because I don't think you can say it's hip and groin or it's hip and pelvis. It's the whole thing as a unit. But the whole thing as a unit, when you're looking at power creation, that's the hub for power creation really within speed and power-based athletes. So yes, soleus might be one of the strongest muscles in the body, if not the strongest. But when you're really looking at peak torque in high-level sprinting and running and kicking and the speed in which you kick a ball, you're talking way over 9 times body weight. On impact loading and the triple jump, it's like we measured it with Philip Sadoru when we were working with him, and that's 15 times body weight going through his hip. So the forces are just huge. And that really then just comes down to capacity, tolerance, and how much you can build up. So again, I would just call it supply and demand. There's a huge demand from the sport, and then you've got to build the supply up for the individual. And if you don't get that right, and that could be in training capacity or individual capacity, that's when you're going to potentially start to get an overload in injury.
So what is the difference? What are the differences between male and female, and why the site of injury changes? Is it purely anatomical?
No, I don't think it is. Because for a number of different reasons, although the reason why I hesitate is there's more evidence coming out more recently starting to look at that. So again, the advantage of being slightly old is that you can remember 15, 20 years ago when we started looking at the difference, and we talked about, well, width of pelvis and angles going into the groin, much like you would talk about with a Q angle for a knee and patellofemoral joint overload. And really there was no evidence around it. And so the morphological, so the structure of the body may not make a difference. Certainly muscle mass and the forces being produced may make a difference. And there's an argument certainly from Bill Myers in the US, who deals with all the core muscle injuries that you would hear about, particularly if you watch American football, where he'll talk in terms of the muscle mass and the lines of force that's created, where the lines of force from the male pelvis tends to be more straight down and less diagonal, whereas the female lines of force in the muscles may be slightly more diagonal. However, there is increase in evidence more recently on pubic joint related around the angles at the pubic joint. And certainly someone like Professor Childers in London at Fortius has looked at the quality of the plaque and the anterior pubic ligaments and how that's significantly stronger in the female pelvis than it is in the male. And a number of years ago, I used to run a complex groin clinic with a doctor called Mark Witherspoon, who works for Southampton in England cricket, and then another radiologist, a guy called David Connell, who's like one of the leading lights in Australia. And what we found was our main population for groin pain was young men playing sport, either weekend warriors, recreational athletes, or professional athletes. And our female population were usually young athletic women trying to get back to sport or physical activity too quickly postpartum. And so something's happening postpartum where we believe that you're probably overstretching or disrupting those anterior ligaments. You're losing the ability to control. You may not quite have the muscle coordination or mass, and then you increase the load too quickly. And there'll be number of other factors around hormonal profile, elasticity in the system with young women. But certainly there's a number of different factors that's not just morphological in nature.
I remember speaking to Enda King on this topic, and recounted a scenario when I was as a player at a football club, lower league football club, and it seemed at one point it was almost like every quarter there was a player that came up with a groin injury, and that person was sent off for surgery. And it seemed a regular thing. I don't know if it was the particular physio that had, I don't know, just that was his route to fix these problems that were occurring. But from your point of view, how can we differentiate who needs surgery and why? Potentially, maybe not using that example per se, but using various examples out there where clinicians may think that surgery is the way to go.
Yeah, so I think the decision-making process around surgery becomes quite multifactorial, and we've certainly advised surgery for a number of different reasons, some right, some questionable at different moments in time, and it's usually because there's multiple factors influencing the decision-making process. Certainly from a clinical point of view, I think, I'll start this by just sort of regaling another kind of story that's very similar to yours, but from a slightly different perspective. So I remember when we first started in groins, again, like I said, nearly 18 years ago, and there was those of you old enough to remember, there was a guy called Dean Richards, who was an ex-England number 8 for rugby,
Yes.
and head coach at Leicester. And the classic was, and I know his physio team very well up there, and the classic was every time they got a groin injury, he would send them down to the surgeon. The surgeon would say they need surgery. The player would get scared, come back, do their rehab really intensively, and invariably they never had surgery because they did their rehab intensively. So, and if I spoke to the late Jerry Gilmore, who I worked with for a very long time, and again, he's got more than 30 years worth of experience in groins, his comment would be he's seen a significant reduction in groin surgery as there's been an improvement within core stability, for want of a better description, but in terms of the functional load transfer across the anterior pelvis. So there's big components within that. So I think from a time point of view, there's been a significant shift. Having said that, if we just take football as a classic example, where we're looking at 16% to 20% of everybody will have a groin injury or of your injury sort of profile. So again, like you say, 1 in every 4, 1 in every 5 is going to present with something like that. The game's faster, the players are bigger, they're stronger, the ball's moving faster on the pitch, and it's in play for longer. So it just increases your exposure. And so while we see this transition, I think we're also still trying to physically play catch up towards the sport itself. In terms of just specifically answering it, I think the key really is that your physical signs should match up with your subjective complaint of pain. And if the pain is disproportionate to the physical signs, then you probably got tissue damage beyond the point of repair. When we start to look at groin surgery, whether we're talking abdominal or adductor surgery, my classic would be with abdominal is if they can produce force but it's painful, and you've got any palpable gaps or palpable issues within the inguinal canal. Now, whether you're doing that as a practitioner or whether the sports doctor's doing it, and they fail a period of rehab, whether that's 2 weeks, 4 weeks, 6 weeks, you'll generally know within 2 to 4 weeks whether they're going to succeed within rehab. And we've had a number of players come to us, professional athletes, who we've looked at them and said, nah, this is surgery, but they want to go down a conservative route, and at 2 weeks, 4 weeks, 6 weeks, they fail their markers, and so you then go through that, and that's a really good process psychologically to let the player adapt, as well as tick the boxes in terms of doing your strength work before you go down that route. And then there'll be certain people who've been told they've got surgery, but they've got some obvious deficits, and as they start to load, the pain subsides, but the pain is usually fairly consistent with their physical signs. So it's usually that really trivector: pain is disproportionate to physical signs, and then they start to fail the loading process, where they just can't put enough load through the tissue without provoking symptoms.
So is there a particular, and this might be a rehash of what you just said, but
fine.
is there particular reasons why certain people recover without surgery and reasons why others don't and have to go that route?
Yeah, so I'm not sure that when we start to look at abdominal related groin surgery versus adductor related groin overload, there's so many complex structures, from contractile tissue, non-contractile tissue, nerves, and then the bone interface, what we would call the emphasis, there as well, all of which have different healing timeframes. And a lot of the time in the elite level in sport, we don't always give it enough time to heal. So the key real question is get your diagnosis right. If you get your diagnosis right, then it makes a big difference in terms of where you're trying to go. And that sometimes requires quite extensive sort of workup in terms of how you look at the structure in the area. And then, yeah, like you rightly say, there'll be lots of people who may not have done the specific conditioning in that area for a while, and then the tissue has gradually fatigued and been overloaded, and as soon as you bring them out of that repetitive strain sort of level in elite sport, they can build up their capacity again and start to return back. I think the final sort of comment on that would be, when we're looking at like groin related injuries with kicking, it's just the speed that you kick the ball at, the speed of limb movement. There really is no substitute for training that area, because you're looking at 500, 700 degrees a second the limbs moving at, which is, we can't train that within the physical environment. We can start to add in different methodologies to try and condition the tissue, but there's a certain component of building capacity on the pitch and building the capacity through training, and that, you know, like any training sort of stimulus, that needs to be managed very well in terms of progressive overload to get the tissue to adapt. And sometimes some people just have gone too quickly on that level, or they've undercooked it for too long, and then they've got a spike in training load, and that's what causes the issues. And then you get the training load right and they recover much faster.
So do you think, and this is probably jumping ahead of the list that we're kind of working through, but do athletes have to stop playing to be able to recover from this? As you just mentioned, I know this is a big question. There's lots of interplay here, but do we have to remove them to readjust that training load, or can we do that on the fly within a training session so they're not missing out on all the good stuff that's going on day to day?
Yeah, so I mean, I think the simple question is that most groin overload, if we want to give it that kind of umbrella term as opposed to the specifics of the injuries, of the different sort of subcategory injuries, you know, the classic comment is they don't stop you from playing, but they just limit your performance. So we'll have lots of people that are just feeling like, yeah, I'm at 60, 80%. I can pass the ball, I can run, but I can't really put some shape on the ball. I can't really put my foot through the ball. There's, you know, everything has to be controlled. And if I do, then I get sharp pain and I'm a bit incapacitated for a couple of minutes, and then it kind of settles and I'm able to go again. So I think it's very easy to sort of keep people ticking over and manage them. And then that comes down to the bigger question as to, you know, the relevance of the individual. You know, if they're 80% fit, are they better than the next person coming in, etc., which are always the arguments that get posed to you by coaches along those lines. So it's finding that balance between meeting the athlete's demand, meeting the coaching demand, meeting the sports demand, but then also as a medic, you know, part of our job is to protect the athlete from themselves sometimes, and protect the athlete generally, but then also as a performance sort of scientist, it's to push them to that red line and get them as close to that red line as possible and keep them there for as long as possible, because that's, you know, it's easy to stop injuries. You just don't train very hard is our classic statement. But if I want to win stuff, I've got to go right to that top end and push my body a little bit. And that's a difficult balance to strike. But yeah, I mean, I think for the general everyday, it's an overload related injury. So if you want to just strip that back, we need to reduce the load and then build it back up in a measured progressive overload sort of manner, and then you can build capacity. So it would mean dropping them out of training, and whether that means complete reduction in training or whether that means modified load to reduce some of the markers. So the classic would be allow them to run if that's not an issue, but don't allow them to kick, as a simple example. So they can do part of the training, but they can't do all the training. Classically, if that was, say, something like rugby, you could structure that. Football's much harder, so from that perspective. So again, depends on the demands.
So our hypothetical athlete has come in, groin pain. How do we, and just coming from a rehab point of view, how do we decide what we include in that rehab program? Is there some basic core things that go in there no matter what, and is there some supplementary things? How do we decide how to structure that?
Yeah, totally. So I think the first question is, and I think this is probably what I see the most, is does the source of pain and the tissue that is producing pain need to be loaded or deloaded? And that's the first question. And I get a lot of people coming in with adductor-related groin problems and adductor tendinopathy, and they've been loaded, but their adductors are the strongest part of the chain when you assess it, and their abdominals or their hamstrings are not functioning as well, and so you need to reduce the adduction load or adductor load, depending on how you want to define it, and increase the abdominal, hip flexor, hamstring maybe load from that point of view. So that's your kind of first question is, am I increasing or reducing the load? And I think a lot of that comes down to where are we from a capacity and or strength point of view, which requires a little bit more sort of investigation away from just the pathology. And that's part of the trick, is examining the individual from a pathology, pain source point of view, and then examining the individual from a function perspective. If I was to give you some general answers, the adductors are, as a group of muscles, they adduct and they bring your leg across your body, so they're key within the kicking action, but they're also a significant hip flexor. And there's an argument that adductor longus is the second most important hip flexor behind iliopsoas. But they're also significant hip extensors. So once you go above 45 degrees hip flexion, they become your most significant hip extensors. And there's some very good squat mechanics research saying, well, actually, the adductors are the main muscles that bring you out of a squat, and they're the main muscles that produce hip extension, and adductor magnus offloads the hamstrings. And so we see all of that there. So you've then got to understand, well, maybe the adductors are overworking because the hip flexor complex isn't good enough. And iliopsoas, which also has, well, psoas major, has an adduction moment arm about it, isn't doing its job properly. So maybe we need to increase iliopsoas. Or maybe the hamstrings and the glutes are not doing their job properly, and so we need to increase the hip extension function to take some load off the adductors. And then what makes it a little bit more complicated is that your abdominals also aid within the hip flexion and control hip extension moment arm. But if we deal with the hip flexion sort of moment to it as well, your abdominals also control, particularly your oblique side flexion, which psoas also controls. So my right-sided psoas is a controller of left side flexion. And so that becomes quite critical in terms of the way the abdominals, the hip flexors and the adductors work as a unit, and getting what I'd call sort of a synergistic or a balance across that whole pelvis and that anterior chain. And certainly I've gone through that phase in strength and conditioning where everything was about posterior chain, and maybe sometimes we don't always focus on the anterior chain enough and how we control that. And then we start to look at, well, my adductors in sprinting, which comes all the way back from the Germans, from Weimann's research in 1995, they decelerate hip extension in running mechanics. So my adductor longus decelerates hip extension. So if I spend all my time increasing my glutes and hamstring strength to produce more hip extension torque, well, then I increase the relative demand on the adductors. So our very simple statement is, for every adductor load you give somebody, you should give them an abdominal load to balance the pelvis. For every abdominal load and adductor load, you should give them a glute load so that you're always balancing. So if I really simplified all of that down, I would say hamstrings first, because hamstrings producing that extension moment, they also produce adduction moment at the hip, and they help to control the pelvis as a primary lever arm for producing posterior pelvic rotation. And that becomes quite critical. And if the hamstrings are inefficient, your adductor load will go up. Then I would look at abdominal load, in particular oblique bias. And what we see is a lot of people that do a lot of oblique control work, but they don't do maybe enough hypertrophic stimulus and get enough cross-section area, enough density of the myofibers. So what you then get is you'll get a passive viscoelastic stiffness, and the passive viscoelastic stiffness then gives you that control of the pelvis against very high torques without having it to be reflex mediated as a sort of muscle spindle Golgi tendon organ sort of reflex as well, even though you're supporting that as you retrain movement. And then you support everything with a good sort of hip flexor program as well. And that would be the specifics. And then my final comment on that would be, I would always pull all of this back to, what does normal running look like? So normal running is, have I got the calf function? Have I got the quad function? Have I got the glute function? Etc. as a muscle capacity. And then what am I looking at technically? Because if we can't run, then we're always going to struggle to kick and then kick on the run, as kicking is a flexion to extension sort of open chain movement, which is part of what you're conditioning when you're running anyway. So hopefully that, in a roundabout sort of way, gives you lots of different answers. But it's about addressing the whole kinetic chain for me, really.
Of course. One thing I just want to pick up on. So was it something that you went too deep on in terms of the posterior chain and forgetting the anterior chain? And is that something that changed for a particular reason?
No, I don't think it was. I think I was just always fascinated that. And again, I think this comes from the athletics background, right? Where when you look at track and field athletes, everyone go, okay, posterior chain, glutes, hamstrings producing hip extension force. But all you have to do is just look at them front on. And, Michael Johnson, Mo Farah, whether you're looking at a 10K runner or a 400 meter runner, they just have humongous quads, right? So the first point is you have to produce vertical force. And that's my kind of engineering background coming in, that if you go back to Novacek's paper in the 80s on the biomechanics of running, the first comment is, in order to start running, you have to produce vertical force against gravity. And that's the critical thing, and that's all quads and calves. And even if you dial forward now to the sort of Dawn paper and all of the biomedical engineering stuff that's been done with Marcus Pandy and those guys, again, now they're just saying, right, it's all about quads and calves. You've got to get that right first to produce your stride length. And then once you've got your stride length, it's about hip torque to produce stride frequency. So stride length gets you up to 7 meters a second, and then hip torque gets you beyond that. So I was just always fascinated that we had this very posterior chain bias, and we looked at track and field athletes, and a lot of them have really amazing anterior chain as well, and it's trying to get that balance right. So it's probably not so much that I went too far down the posterior chain route, but it was trying to wrestle with myself and really understand, well, what's the science between when do I go for what? So do I go for anterior chain first to give them the vertical force to allow them to run, or do I go for posterior chain to support the groin and take the stress off the groin and give myself lumbopelvic control and hip torque, because that's going to be the end stage, and that might be the biggest variable that I need to get back first. So it's a constant sort of dilemma that you go through as a clinician between, well, what do I go through first, and where's my lowest hanging fruit, for want of a better expression, to get the athlete back as quickly as possible. So it's a constant judgment call.
As you'll be more than aware, in the strength and conditioning world, people become obsessed with speed development.
Yeah,
absolutely obsessed. Now, when it comes to introducing running mechanics, you probably go to any football club, any rugby club now in 2022, and part of a warm-up, with a good, bad or indifferent, there'll be some sort of introduction of running mechanics from the performance coach in there. When it comes to mitigating and trying to reduce the risk of hip and groin injuries, is it running mechanics something, and as we know it, when it comes to running mechanics and the influence of the athletics and track and field world, is that something that is going to potentially help when it comes to mitigating this risk? And if so, is that something that you would introduce during a rehab session to help these rehabbers along the return to performance journey?
Wow, there's a huge amount in that. So yeah, I think we just got to start with the first point of call is what do we think is the minimal dose that we need to apply to the individual to try and reduce the risk. And if that comes in the form of running mechanics or another stimulus, then what do we need? And what's the goal and the outcome of where we are? So I think if the goal is to give a running mechanics stimulus to improve the technical component of running and get them to run more like sprinters, I think that's really, really difficult. So if I look at, I was very fortunate in my career that I worked with Christina Huragu for 8 years. But if you look at Christine as a 400 meter runner, she'll do probably near enough 2,000 meters worth of high quality speed work per session 3 times a week, plus all of the drills, which will probably be about 1,000 meters, 500 to 1,000 meters worth of work at the beginning of every session. So we're then talking 7,500 to 9,000 meters a week of high quality speed work. And that's done week in, week out, 9 months of the year before you get to race season from that point of view. So the dosage to really get good running mechanics and to really condition the tissues to that kind of load is very, very high. But they're horses for courses that's specific, right? So if we then flip that to football and we say, right, well, okay, or even rugby, and we say, well, maybe they're doing 1,000 meters worth of high quality speed work per session or per match. Again, it's a very, very disproportionate amount of load. So I don't know that you'll necessarily see the same sort of dose and training stimulus to get the same kind of response. That said, if our goal is to try and condition the tissues to limb speed and to shorter foot contact and to give them some kind of cerebral stimulus, so we're getting a tissue stimulus and we're getting a cognitive stimulus and a sort of a parietal lobe, as in getting the right part of the brain to work to get the patterning from a central nervous system, or if we go down a Franz Bosch point of view, we decentralize it and get the spinal reflex working, then yes, I can see that will have an influence, but we're not trying to turn them into runners. We're just trying to condition the tissue by doing what we're doing, which then the outcome and or the coaching point probably looks slightly different, because you're not necessarily saying, well, we need to hit the right positions from a running point of view, but you're saying we need to get quick limb movement and short foot contact, which is a very, very different coaching cue than it would be, I want a high knee, I want you to increase your stride length, I want you to do those sort of things, which is, again, really difficult if you're in football, rugby boots on a soft pitch versus, spikes on a Mondo track. It's the ground reaction forces are completely different, so the elastic moment arm's really different. So I think that becomes quite critical in terms of what you're trying to do and where that decision making process comes in. And then there was another point I was thinking of, but I think I've probably lost my train of thought. Just say the part of the question again, if you can remember it, because I think you went slightly off the cuff.
No, that's fine. What was it? Let's come back. Let's come back. Because I've got another point. We can revisit that. So back to the hypothetical rehabber coming through. When it comes to change direction mechanics, is there anything positionally that you're looking for to give you an indication of how that person is successfully navigating that change direction? I was thinking of the clinician, the coach who's maybe going through this process and listening in. Is there any key positions or key things that you're looking for during a change direction that you could potentially communicate with us?
So again, I think that's a really interesting question. We addressed that quite early on in our teaching pattern, where you've got a rugby player change of direction, and then we've got a basketball player change of direction. So footwear, surface makes a huge difference, right? You've then got the rugby player, they're keeping their centre of mass within their base of support, and they're using muscle forces to try and change the direction, whereas the basketball players throwing their centre of mass outside of their base of support. And therefore so the rugby player will be using concentric, eccentric. The basketball player will be using isometric sort of contractions predominantly to stabilize. I know that there's been a big bunch of work that's been done by Santry commenting on the difference between, high level change of direction versus low level. I think my comments on where that sits, and I think that's a very good place to start, would be, well, we need to understand that at different speeds, because again, if you're testing that over 5-10 meters and then you're changing direction, well, in 5-10 meters, unless your name's Usain Bolt, I'm only getting up to 5 meters per second kind of speed before I change direction. Well, that looks really different than if I'm bombing it down the wing as a fullback and an attacking wing back at 7-9 meters a second, and then I want to change direction. So the mechanics change. And then I think the next part you need to understand is, well, if we start to comment on the way people move, which is what those papers have done, and they're great for doing that, what we're doing though is we're commenting on what's happening, but we don't necessarily know why. So I might be moving in a particular way because I don't quite have the right muscle mass, or I've learned to move that way and that's the most efficient way. And I think some of the best examples is if you can go back to the 2015 Rugby World Cup and you watch, I think it's Umunga coming out the back. No, it's not Umunga. Nonu, sorry. Coming out the back and sidestepping the Aussie to go under the post to score the try. Like, he threw his centre of mass way over to one side. And then gravity, when you throw your centre of mass, gravity is 9.81 meters per second squared. So he's accelerating at 10 meters a second to move around the guy, which is phenomenal at whatever body weight he is, 100 plus kilos. So it looks really, really different, but he's probably got the muscle mass and the strength and the capacity to do that where somebody else possibly wouldn't. And that might be a more efficient way to move to throw your centre of mass out, but you need to have all the muscle capabilities to do it. So I think it's about trying to coach. When you're looking at this, you then come back to it and look at it in a coaching eye and then say, well, does it look efficient? And is the person moving? And does it look effortless? And does it look free? And I'd almost come back to that and coach the individual around the way the individual moves and what feels right. as opposed to necessarily trying to get into very specific sort of criteria of this is how people move with change of direction, which I'm just not convinced that if we were to roll that out across lots of different people, lots of different speeds, lots of different surfaces and footwear, I think you're going to see multiple different sort of patterns occurring. And then you start to drill it back down to for what I would call their phenotypes, so their muscle strength, their body build, their building, their morphology, the way their body's built, sorry, I should say. We'll then see there's so many different variables in terms of how that person moves, in terms of where we're going. And I think we bring that back full circle to your question around sprinting, and pull that all in. Again, I've been very, very lucky that we travelled the world with athletics, and I worked, because Christine trained with the Jamaicans for a long time, so I worked with Usain's coach for a long time. I worked with Coach Francis with Asafa Powell and those guys for a long time. We went over and spent time with Mike Smith in LA, etc. So you speak to all of them, they all have their own methodology of running. But if you strip it back and you analyse Michael Johnson, Frankie Fredericks, Asafa, Usain, all the best 20 odd top 100-meter sprinters, they all move differently. So if they all move differently and they're all the best in the world, then maybe there isn't just one way to move, and maybe there's some common denominators about what they're producing when they move, which we may or may not know all the facts to yet in terms of vertical force, hip extension, torque, etc. as an example. And then the same thing gets transferred towards change of direction. So I think we need to observe the way people move. I think we need to understand it. And then I think there's a bit of a judgment call in terms of how you coach it versus what the parameters are around what ideal movement may or may not look like for that person.
Just taking a more global look at that rehab journey, is there any particular markers that you would look for throughout that, however many weeks has been predicted that this player will get back to full training? Any particular markers that you would look at no matter what that person presents in terms of how they run and how they move, in terms of a structure?
Sure. So I think the way we like to work, and I like to work in particular, is we have different markers for different stages of the rehab. So early stage rehab may well be, can I get the abdominal to adductor or adductor to abductor ratios right, as a very simplistic thing. The evidence is very clear in the research, and so that's a good starter for 10. But as you start to get into more specifics, then I think those markers need to move away from pathology, which is what I would look at in the first instance of pathology and pain markers. So whether it's squeeze test, whether it's strength ratios, so it's all about provocation. To then kind of, for want of a better description, we have a 7-stage kind of rehab process. But if I went to sort of stage 2 in sort of global terms, now I'd be starting to look at, not necessarily provocation and pathology, but function around the groin. So that's where the adductors to abdominals, adductors to hip flexor ratio may well kick in. And then as we start to move into stage 3, as we're kind of getting ready for return to running, now this all has to transition into running specific markers. So if I was to go through that in a very clinical sort of setting, I would say stage 1, I want reduction in pain on any of my key marker tests. So classically that would be a squeeze test, or it might be some kind of abdominal load test, or it might be some kind of adductor torque test. And that's my sort of clinical marker on the bed. But I'd also want to see some improvement within adductor muscle strength. So either it was low and around 20 kilograms or something like that, or 2 kilograms per or 2 newtons per kilogram sort of force going across the groin, and I want to see that progressing up to 25 sort of kilograms or so in terms of ability to take load and stress through the area. But I'd also want to see some kind of improvement in capacity within the rehab setting. So can they maintain an adductor side bridge? Can they do ball squeezes for longer with more force? Can they do more abdominal loading for a longer period of time than what they could do before? So we're seeing something on the plinth, something that's functional, and then something that's kind of movement function specific, if you want to describe it in that way. Then when we get to stage 2, now it's about balancing the pelvis. So I'd want to see adductor to abdominal ratio, but I'd also want to see adductor to hip flexion ratios. and hamstring to hip flexion ratio starting to come in as just an individual talk around that ipsilateral side, so same side, so right hamstring to right hip flexor, right adductor to right abductor. And I think just looking at that very simplistically, you start to see where the weak link in the chain is, and you start to train it. And invariably, it's not where the tissue source is. Our kind of global overriding comment, which I should have made earlier, was most elite level athletes we actually find get injured where they're strongest and not where they're weakest, because they compensate to their strongest area, which is their path of least resistance. Most of the sort of aspiring athletes get injured where they're weak because they're trying to produce force and they just don't have that capacity to do it, and they don't quite have the same patterning and compensation strategies. So we'd be looking for that torque, and we'd look at that both from handheld dyno point of view, or using something like a Kangatech, or using some other kind of metric to measure it. And we would also have something functional, but we would probably be going more down, can I do a split squat for a certain amount of reps? And we have particular protocols around split squatting and developing that torque around the pelvis that we look for. So again, we've got something that's functional, which should be correlated. And then when we get to return to running, we're then now moving to this kind of vertical force sort of element. So what's their isometric squat like? What's their peak plantar flexion force like? Have they got some RSI, some reactive strength index markers that we can look at as sort of preemptive towards running, so that we know that they're getting close back to the physical capability? But then we start to expand it a little bit more. So we start to say, right, well, what does right hip flexion to left hamstring look like, or left hip extension torque? Because it's not just left hamstring. When you're measuring on a Kangatech or a handheld dyno, you're looking at flexion torque to extension torque, which is not muscle specific, but that's critical. So it's that flexion to extension torque on the opposite limb that then becomes critical to running, that I'm not sure that is always looked at from a reduction in risk. And if we haven't got that flexion to extension torque right, then you're going to ask other muscles to kick in to try and take over, and that's when you're more likely to get overload again as well. So we're shifting it more towards that top end functional question, away from the pathology as we go through that rehab phase.
One of the last questions I'm going to come to on this before we dive off in another direction: key ratios, James, that you mentioned there.
Yeah.
Is there any ones that you would pick out in particular? Any ratios that you could give us an insight into what you're actually looking for between these muscles?
Yeah, sure. So I think there's two ways of answering that. We started doing ratio. I can't remember. We started doing ratios probably about 10 years ago. And I was very lucky when we was in the IRU, which we kind of started in 2013, 2014. We had two amazing S&C coaches. So Nick Chad, who was at Man City, who's now gone to Salzburg, I think he's gone to in Austria.
Yeah.
And then Fionn McPartlin, who's gone over to Red Bull in LA. So I was fortunate enough to work with them. We collected about 1,600 data sets across Olympic athletes that we haven't published, right? Because it's Olympic sport, and if I publish it, then, Enda King and the Irish come out and beat me, which is not something we want to happen. No, I'm just joking, Enda, just teasing you. But yeah, so we've got all these data sets, and so I think a lot of it comes down to, there's some very sort of global terms. So we would generally say, adductors, you want about 30 to 35 kilograms, and abductors, you want a little bit less than the adductors, right? As a simple sort of message. However, when you really look at the data that's out there, and I go back to Professor Newman's work from 2010, where he looked at torque ratios across the hip. So without looking at specific numbers, but extension should be your primary torque producing force. Then flexion should be 10% behind extension. Adduction should be 20% behind extension, and then abduction should be 20% behind adduction, and abduction should be 60% of extension, all right, as a ratio. So I'm not necessarily worried about the top force. So can you produce 25, 30, 35 kilos? What I want is the balance from extension to flexion, adduction to abduction. And the big thing we see is lots of people focusing on abduction because they think that's right, and for whatever reason, and I think that's perfectly reasonable, but the abduction to extension ratio needs to be right. You should be 40% stronger into extension than you are into abduction, as a general ratio across the hip. I think then all of those things need to be factored into size of the individual, limb length in particular, femur length, their body weight, their height, all those sort of things come into play because it affects their torque at the hip. My final comment would be is I'm not again convinced that we've quite got this right, and we've started shifting this way a little bit more the last 2-3 years, in the sense that we've got these numbers that are out there and they're all relative to pathology. My comment would be, well, we want to look at those numbers relative to performance and relative to running mechanics. So rather than have I got your adductors up to 30 kilograms, in order for the way you run and you kick, what do we know is your norm, or what do we know is your ideal of where we need to get you to in order for that part of your body to be able to tolerate it? And I think we're still exploring that at the moment and understanding that a little bit more from a research and or practical perspective. So very simply, I would say it's about ratio around the individual hip rather than absolute numerical number. And those ratios should be looked at and respected. And then it's about the relative number relative towards the demands that player can produce. So, a guy that's moving at 9 meters a second versus someone who, or greater than 9 meters a second versus someone who can't quite move at that speed at 7 meters a second, then those ratios need to be different because the demands on the tissue are really different.
Superb. What a rundown for the last 50 minutes on hip and groins. No problem. We're just going to take a little right turn though. I was let know by the guys at Hydro who have been a part of the podcast for the last month or two, which has been great.
Brilliant.
That you are now involved with those guys. Tell me how that came about.
Yeah, just again, very fortuitous. I sound like I'm just one of these, guys that floats around in the ether and has this laissez-faire attitude, and I just kind of fall into things. Look, very fortuitous. Met some guys through the clinic actually, and started having some conversations. Got introduced to Warren and Raj. We're part of Hydro. And again, it's just something I've always been interested in. It's really interesting in the sense that we started using occlusion work back in, I can remember the first athlete we used it with was back in 2007, who'd had a knee operation before what would have been the World Championships in Osaka in there for a long jumper. And I was very lucky that I worked with Raphael Brandon, who you may know. So he's got PhD in running mechanics, but also recently head of research and development for ECB. And then Pete Atkinson was the guy that really brought it over. So as the EIS kind of lead. And again, we were very lucky that Duncan French was also part of that setup. And Duncan's obviously got a PhD in that kind of area. So, we had kind of a brains trust around it. And we started playing with it a lot back in those days. And then over the various years, I've been exposed to different sort of devices with sort of Suji being one of them, and people asking me to sort of what was my thoughts on this sort of stuff. And we've always used it. And then Hydro came in and it just made a lot of sense. You've got a piece of equipment that can be embedded into clothing. So it's user friendly, it's quick and it's efficient. In terms of what you're doing, there's lots of safety protocols and research that's going into that kind of area to maximize how everybody uses it. And as with every product, it will be evolving over a period of time. And it brings something that's cost effective to the market and to athletes and to the general population as well that want to use that kind of device. So it just made good sense. And I thought, with my experience and background and my interest in doing new challenging sort of things, it would be, well, look, can I add some value to this, and can I make it available to the population in a safe and sort of cost effective way? And so it just made perfect sense to get involved.
Perfect. Where do you think it fits in terms of performance, and I suppose your area, which is predominantly rehab? Where do you think blood flow restriction fits?
I think it fits across the board. So I don't think my comment, again, if we go back to my comment I made earlier, it's really easy to stop people from getting injured. You just don't train hard, right? So, if you're looking at, I would say performance, rehab, prehab, that whole sort of thing, it's about understanding the individual, understanding where their risks are. And you're always kind of topping up and balancing everything with an individual. Certainly, I give you a slightly different, slightly off the cuff example, but I just think it's a fascinating conversation. Like Raf, Brandon and I, years ago, when we were dealing with Christine, so she had bilateral Achilles injuries and Achilles tears in 2006, came back, won the World Championships in 07, and then Olympic gold in 08, and then in 2009 she got a nasty pars fracture with a high hamstring tendinopathy on the right hand side, and in 2010 she had a complete rupture of her rec fem with a 10 centimeter retraction and 80% muscle loss, which is really significant injury for a sprinter. And in those days, this is 2010, we didn't surgically repair them, which we would probably surgically repair a lot of them now. We managed it conservatively, and Raf and I sat down and went, how do we get this athlete back from this injury and get her to perform at the highest level? And we did that over, a little bit of light refreshment, because that was the right way to kind of stimulate the brain. And we kind of came up with this equation, and I don't think it's set in stone, but we basically said, force production / absorption plus rate of force development equals tensile load plus elasticity, as a way of trying to balance the individual. And we knew that Christine could produce an absolute bucket load of force. She was a 70 kilo athlete that could squat 130 kilos. She could hang clean 90. She's ridiculous. Her rate of force development was terrible. Well, not terrible, that's being horrible to her. That's inappropriate. Just her rate of force development could do with some work. It's probably the right way to put it. Her elasticity could do with some work. Like, she spent a long time on the ground, but she did that because she was so strong, and that could allow her. So going back to traditional running mechanics, getting her to do quick foot contact is not the right way to go. And actually you increase her risk of injury, but her tensile capability was off the chart. So she could produce a lot of force through a very big range. And what we found with Christine was, well, if we got her too strong, we actually increased her risk of injury, and she got slower. So this whole balance of, performance versus rehab for us, just taking that one variable within a simultaneous equation that we produced, right, we could, dial it up, dial it down, depending on where we were. And we found out we needed to get her strong enough to reduce the risk of injury, but not too strong that actually her performance went down, but strong enough that her performance was still good enough. So it's that constant battle. So to specifically answer it on BFR, I think, look, what we're really looking at is how do we optimize metabolic capability within the muscle and muscle tensile and force producing capabilities. And there's a number of ways we can do that, whether that's be producing high force through the muscle, whether that's eccentric load for that non-contractile tissue, whether it's BFR to increase the cross-sectional area and the viscoelastic property, whether it's BFR to help with capillarization and mitochondrial density, which will then help with ATP and efficiency of how you use those myofibrils. I think there are so many different ways you can use it, and I think we're only just scratching the surface now to all the performance and rehab and then recovery stages of how we can use it and where it fits across that whole spectrum. I mean, we've just been really lucky. I've been working with a Premier League footballer who's had a very nasty sort of injury at the moment and rehabbing back, and so we've been using BFR at rest at the moment, of an evening after doing 5 hours worth of intensive rehab every day, and just chilling out in an evening to try and help with recovery. And like, he's done a lot of load. He's done, I think, 8 different weight training sessions within about 4 days, with just focusing around hip and thigh function, and he's had barely any DOMs from that, and we've pushed him reasonably hard on some of those levels. So I think there's some really fascinating areas to come out of BFR at the moment that we're just scratching the surface. And so again, that's another reason to be involved in Hydro, because it just allows us to experiment and explore and look at all the performance and the cross links between performance and rehab and medicine.
Yeah, I think it's an interesting area. I've had a couple of people on the podcast discuss it in length, but I would guess that there'll be more in the future as it kind of definitely takes hold from people, through people like Hydro.
Yes.
So James, thank you very much. I know you've got a call in 25 minutes. So I wanted to give you a little bit of a buffer, because I know you're back to back on many things in your professional life. If anyone wants to catch up with you, get to know more about your business ventures, education, what you're doing day to day, where's the best place for people to get hold of you?
So just I'd just say just contact the clinic. It's probably the easiest thing. So info@chhp.com, and that'll come straight through to me. My personal email is jamesmoore@chhp.com, all one word, all lowercase. So yeah, no problems at all. I'm happy to take anything. Just as I say all the time, just appreciate that I am busy. So I nearly always scan every email, but I then maybe might take a day or two to come back to you, or 3 or 4, depending on how busy I am at the time. But yeah.
And social media, James?
At jmoore physio is sort of my Twitter handle, and yeah.
Amazing. Well, like I said just right at the start, I do appreciate you giving up your time, because I know you're a very busy man. So yeah, thank you very much. Thank you very much for your insights, and good luck with everything that's going forward, including your partnership with the guys at Hydro.
Thank you very much. It's been an absolute pleasure. I really enjoyed it.
Cheers, James.
Cheers, Rob. Thanks, mate.